The next speaker we have got is Nicolette Graham, who's going to speak to us about embracing the cutting edge impact of transformative quality improvement program on surgical site infections in children. Nicolette is a pediatric clinical pharmacist specializing in infectious diseases and antimicrobial stewardship. Her research interests include all things bugs and drugs. Over to you, Nicolette.
Thank you so much for the invitation to speak. And gosh, following on from two great presentations by Rochelle and William, thank you so much for including me. I'm presenting this as part of a team. Dr. Vish Patel and Melissa Cullen are two excellent clinicians who work here at the Queensland Children's Hospital and have been doing some groundbreaking work in the surgical site infection space. And I've got the privilege of sharing our team's results with you this evening. So just to kick us off, I think it's always good to take a leaf out of the book of a cycling champion team. And this cycling champion team didn't start at the top, they started at the bottom and worked their way up. And so David Brailsford coined it, the aggregation of marginal gains is every 1% improvement we make in every small thing that we do, as in every step that we take to achieve a goal, gives us that cumulative improvement over time. And certainly from a surgical site infection perspective in kids, that's something that we've embraced. So at the Queensland Children's Hospital, about 5 years ago, we started on this journey looking at our surgical site infection rates through our quality improvement program that's done collaboratively across not only Australia, but also the US. And in terms of paediatric sites, Queensland Children's Hospital was one of the first Australian paediatric sites to join this collaborative, but certainly since then, many other sites have joined, including adult sites as well. So it's a surgical quality improvement program that's data-driven, risk-adjusted, and outcomes-based. It measures and improves quality in surgical care, and it allows benchmarking across centres, not only within your own country, but also internationally. On the photograph on the right-hand side is Melissa and Bhavesh, who just recently presented at the BMJ Safety and Quality Conference. So our goal at Queensland Children's was to achieve a 50% reduction in our surgical site infection rates over 2 years. And this journey started mid-2022, where we received some not so good news, where we were identified as a significant outlier for surgical site infections in our peer group. And we wanted to achieve this outcome by reducing our surgical site infection rates within 2 years. And implementing a surgical site infection bundle was the way to go. So as with most bundles, there's some specific components to it. And tonight I'm just going to highlight some of those. So given that this is an antimicrobial talk, we can't do this without talking about surgical antibody prophylaxis. And Rochelle has beautifully introduced the topic for us in her talk. We'll also cover pre-op preparation and showering, involving the patient and parents and carers, prep choice and application method, the role of antimicrobial sutures, and also what happens post-op, so wound care, discharge education, and the impact of those. So when we think about the key moments of surgical antibiotic prophylaxis, we know that achieving optimal antimicrobial prophylaxis choice, including drug dose and timing of that first dose, is incredibly important. And Rochelle nicely demonstrated this for us in her talk on bariatric surgery. We also know that those choices of antimicrobials is influenced by MRO colonization, so multi-resistant organisms, including MRSA. Antibiotic allergy can play an important role in choosing either first or second line agents. And then also the length of the procedure, as we mentioned before, and also extremes of weight. So it's not always a one-size-fits-all approach and often needs a bit of individualization. Dr. Sarah Cosgrove and her team in the US a few years ago did a fantastic paper looking at MRO colonization and the impact of that on outcomes in patients with surgical site infections. This was mainly done in adults, but just if I could draw your attention to the comparison between methicillin susceptible Staph aureus and MRSA surgical site infections, we can see that your risk for death is 3 times that if you're colonized with an MRSA, and also your increase in healthcare costs is significantly increased when colonized with MRSA. Length of stay is also increased, although in this case it wasn't clinically significant. When we think about the advent of penicillin allergy and how many patients are labelled with a penicillin allergy for many, many decades, it's important to think about the impact that may have in the perioperative space, especially with the selection of antimicrobial prophylaxis. It is quite interesting looking at this study by Kim Blumenthal from the US, where they showed that patients with a reported penicillin allergy were at much higher chance of receiving second-line agents, including vancomycin, clindamycin, gentamicin, and fluoroquinolones as their perioperative surgical antibiotic prophylaxis. That was also shown to be consistent across surgery types, age, sex, and race, and clinically significantly increased the risk for surgical site infections by 40 to 50%. In paediatric patients, there's a fantastic study done by Dr. Michaela Lucas and her team in WA, where they were able to show that in children we've got an allergy incidence, so penicillin allergy incidence of about 5%, and that impacted significantly beyond length of stay. So patients without an allergy label had a mean length of stay in their cohort of 3.8 days. However, patients with a penicillin allergy label had an increased length of stay of an additional almost 2 days. Professor Jason Triviano and his team at the Austin, who do fantastic work in the antibiotic allergy space, were able to demonstrate that if we're able to provide penicillin allergy history assessment and delabeling, that increases the antibiotic appropriateness 12-fold, but also improve patients' access to first-line therapy by a 4-fold increase. And in the perioperative space, that's really important because we know that patients who receive beta-lactams as perioperative surgical prophylaxis do better and have a reduced rate of surgical site infections. So in our patient cohort, we looked at surgical site infections, and we also looked at surgical antibiotic prophylaxis as one of our bundle elements. And this year we performed a post-intervention audit, just looking at how we were tracking and what changes we need to make in our perioperative surgical prophylaxis education and training. So we looked at a total of 288 procedures of 114 children between the ages of birth to 18. Snapshot of 106 procedures where antibiotic prophylaxis were indicated, about 37% were audited. And as you can see, it was across a range of surgical craft groups. So our results show that as far as antimicrobial choice and optimal timing from procedure start time, we had some improvements shown from the previous audit period. Now, you may ask why I'm highlighting procedure start time when, in fact, our gold standard should be knife to skin time. And certainly this has been a change in our practice in recent years with the implementation of a digital electronic medical record. We have some improvements in that space to make, and certainly when we audited against knife to skin documentation in terms of timing and timing to perioperative antibiotic dose administration, we only achieved about 58%, which is not where we'd like to be. So there's certainly a lot of work in terms of timing of that initial dose that need to happen in the pediatric space. In terms of optimal dosing, and again, greatly appreciate Rochelle's presentation looking at extremes of weight. We certainly found in our audit that pediatric patients at extremes of weight were often the ones who were underdosed in the perioperative period. And that's certainly an area where we could do a lot of education and improvement in our guidelines. Prolonged procedures is another area. And as we have seen in previous talks, the concentration drops off quite significantly, especially when bolus dosing is administered of beta-lactams, which often in children have a very short half-life of 1.5 to 2 hours. So having repeat dosing administered or a loading dose with a prolonged infusion does improve your exposure. So certainly a lot of work in that space to do. And in addition to this, in terms of antimicrobial choice, we noted that our patients with MRO colonization or beta-lactam allergy documented often received second-line agents or didn't receive appropriate cover for their MRO. So we still have a lot of work in this space to do. This is a photograph of one of our surgical registrars who were really keen to improve the work that we're doing in this space and was willing to design a bit of a poster at the hand hygiene station just outside theatre to help our surgeons select appropriate antibiotics in theatre and highlight those important items as in dose, choice, knife to skin time and repeat dosing. What we've also done since then, because access to electronic guidelines is not always that easy within the surgical theatre space, is actually having these massive laminated posters put up on the walls for easy access, but also to support our most junior staff within the theatre space to speak up around perioperative surgical antibiotic prophylaxis choice and dosing and repeat dosing. And that already has made a significant difference in being able to act and those interventions during the perioperative space and intraoperative space to ensure that patients receive appropriate care. In terms of duration of surgical antibiotic prophylaxis, as an AMS pharmacist, this is something that we often are concerned about and is a good quality measure of an AMS program to be able to demonstrate that we do not use surgical prophylaxis for prolonged periods of time. We know that the benefit for surgical site infection prevention happens in that knife to skin time and obviously the repeat dosing for prolonged procedures or high volume blood loss. As a hospital, we have had some steady improvement in this space over time. And certainly at the moment, we're sitting at about 15.3% of our surgical prophylaxis that are still continuing beyond 24 hours. So still work to do in that space, but some improvement shown over years. So moving on to our other bundle elements, which we'll be covering in the next few minutes. One of the fantastic little quality improvement initiatives was around communicating with families. And as part of our pre-admission clinic, families received a text message with a link with some basic surgical information for their preparation of bringing their child into hospital for their elective surgery. And that included a little infographic that demonstrated how cleaning should be done ahead of the procedure. And you may smile thinking about this, but it was demonstrated to me that sometimes it's a little sandpit in the theatre when the child arrives if they haven't received the appropriate cleaning ahead of surgery. So certainly those preparations ahead of hospital makes a significant difference. What we've been able to demonstrate is that these little information sheets are really well accessed and useful to parents. We know that they spend a lot of time reading it, and we're able to demonstrate that in comparison to other resources we use in the hospital that are provided online to families. And certainly a lot of positive feedback has been shown from having some very targeted information ready for families to help them with their surgical journey. We're also looking at how we do skin prepping, and a recent audit demonstrated that we use 75% of chlorhexidine as our prep preference in our hospital, with 25% being povidone iodine. Average prep time and drying time is about 2.4 minutes, and applications mainly done by the scrub nurse. This is in preparation for the next phase of our surgical site infection bundle, looking at do we need to streamline the preps that we use? Is there some better evidence for certain preparations like ChloraPrep that may help us bring that surgical site infection rate down further and may benefit patients with reduced adverse events? One of the new things that we've introduced at our facility, and since the introduction of the bundle, we've now completely switched over, is the implementation of triclosan-coated sutures. Certainly initially there was a concern about antiseptic resistance with this product, but certainly not something that we've seen since implementation. And this meta-analysis demonstrated a 28% reduction in surgical site infections. From a surgical perspective, most of our paediatric surgeons have been very happy to use this suture. They've certainly demonstrated in their individual patient cohorts a reduction in surgical site infections. So it's been met with a lot of praise. And then obviously we need to think about that post-op period. And one of the things we were able to demonstrate early on in our surgical site bundle was that a lot of families were presenting to their GP with concerns around surgical site infections. And we had a lot of variability in how that was addressed. So what we needed to do is implement a system where there is a very clear link between our community healthcare providers who do an excellent and a very important job, and families are linked in with already, and linking them back to our surgical teams when it comes to surgical site infections and making sure that they are diagnosed appropriately and managed in a timely manner. And again, we utilise some clinical information that's delivered by text message. The same information is shared with a general practitioner. And what we were able to do is actually have families take a photograph of the wound and send that back to a specific phone number that's all secure. And that allowed monitoring by the surgical team caring for that patient within that first month post-op, which is the surgical site infection rate concern that we usually have in terms of time period. And this has demonstrated that it's used in about 95% of families who receive this text message. The viewing time is 6 minutes, which is really significant if you think about how limited our online viewing time on occasion is when we flick through different bits of information. So having information read for about 6 minutes means it's really engaging and really important to families. And certainly well above the average use of many other fact sheets that we have available on our paediatric website. And easy access for families through their mobile phone or device has been really successful. For our non-English speaking families or low health literacy, we've also created a health infographic around wound infections, just highlighting those specific signs and symptoms to make it really easy for them to identify and to be able to confidently go to their healthcare professional or link in with their surgical team to ensure that surgical site infections are identified early and treated appropriately. So how are we tracking? So we started back in mid-2022 with a significantly higher rate. So we were sitting at 5.22%, which is well and above what our peer group in the US were achieving for surgical site infections. And since then, we've achieved a 50% reduction within the first 2 years of the implementation of the program. And we are very excited to see our next set of results, which is due in end of November, from our US colleagues in terms of benchmarking to see how we have continued to track. We've got certainly a few optimization components to work on in surgical antibiotic prophylaxis space, but we have a very engaged anesthetic, nursing, medical, and surgical team that are really interested in improving outcomes in their patient cohorts. And this has been nicely demonstrated in this paper by Danielle Donor and her team, where it looked at the important role champions play in improving antimicrobial stewardship in the perioperative antibiotic space with kids. And certainly that's been our experience. We're very fortunate to have Babesh and Mel leading this with their teams, but also the manner that they've engaged with the different surgical craft groups, and also how they've shared the experience with many other centres who are now also adopting NESQIP and this quality improvement program. Thank you very much for attention, and I think the next step is some questions.
Thank you very much, Nicolette. That was a lovely presentation. And certainly, as you point out, actually, you need champions. And at least in my eyes, and I'm sure everybody else who's listening to your presentation thinks the same way, that you and your team are nothing but champions, actually, really, as far as this topic is concerned. And well done, and congratulations on achieving a fantastic outcome of reducing surgical site infections.